All for joining us tonight. I hope you can all hear me well and see my screen. Is that a yes?
I can.
All right. Tonight we're going to talk about shoulder pain and lot of ground to cover here. Where you're going to talk about some basic anatomy. Those of you who are my patients are going to recognize a lot of these slides or the terminology I use. Evaluating shoulder pain and dysfunction. We'll discuss some of the common diagnoses. Dr. Cui will touch on the common diagnoses. Non-operative management, then I'll get back to the operative management towards the end, and we should have some time for questions at the end. These are these two handsome fellows, myself and Dr. Quay, half my age, so he is much more handsome than I am. Thank you for being here.
Oh,
There's A, that we not see, the
Oh,
two feet Charlie.
someone's in the hospital. All right, let's talk about basic shoulder anatomy. Those of you who've been in my office and have heard this before, okay? The shoulder is not like your hip. Your hip is a bony ball and socket, very stable joint. That's why most people don't know someone who's dislocated a hip unless they've had a hip replacement. Unfortunately, it's gone awry. Everyone pretty much knows someone that's dislocated their shoulder at some point in their life, and that's because a shoulder is like a golf ball and a golf tee, but even worse, as I'll show on the next slide, it's like a golf ball sideways hanging from the tee. It's a very unstable system. The corollary to that is that it's also the most mobile and least constrained joint in the body, and that's what makes it so wonderful for us to have, but also such a challenge for us to treat when things go wrong. These are the muscles called the rotator cuff. The rotator cuff is a group of 4 muscles. In fact, on that slide I had up here, if you see on the hand holding the golf ball sideways, those 2 fingers, the ring finger and the middle finger, those are 2 of the posterior muscles on this slide called the teres minor and the infraspinatus. My index finger up on the top is called the supraspinatus. That's the muscle that lifts your hand up over your head. And the finger you cannot see is my thumb. It's facing me. That's the largest muscle, the rotator cuff. It's called the subscapularis. It allows us to bring our hand to our tummy or reach behind our back. So even though these are 4 separate muscles, they have a common tendon. Tendons attach muscles to bone, okay? And as those muscles pull, they pull on the tendon that pulls on the bone and it moves our shoulder. And all 4 of these muscles need to work in unison in order to keep that ball centered in the socket, no matter what position we put our arm in space. And that's very important. So this is how this all works. When we rotate the rotator cuff, as you're seeing there, the ball stays centered on the socket in a normal shoulder. That's how the rotator cuff, it holds the ball centered on the socket and compresses it into the socket, which is important because the socket, similar to this T, is about 1/4 of the size of the humeral head, the ball of the shoulder. So you need those muscles. In addition, you need all of these muscles. There are about 20 other muscles of the shoulder girdle. And you need all of these muscles working in perfect unison in a tightly coordinated dance to keep your shoulder functioning in a healthy manner. And as we can see on this diagram too, is you can see how many of these muscles in the center picture attach to our spine. And that's why a lot of times when you come to the physician's office, you have neck pain or shoulder pain or both, or back pain as well. It's because the shoulder requires all of these muscles to pull on other parts of the body. It anchors the body. And a lot of times back and neck and shoulder pain all go hand in hand. And here's a demonstration of what I'm trying to say with this system. You see in my right hand, the fingers that are holding the ball are going to be the rotator cuff. And then my left hand holding the T, that's like the 20 other muscles. And those other muscles have to move the T with the ball and keep that ball centered. And if there's any mismatch due to injury or inflammation, the ball is going to move around, translate or dislocate. And when it does, if it moves abnormally, things will get pinched. And when things get pinched, you're going to feel pain. Not only that, pain can cause inhibition of these muscles. So it kind of spirals down. Something's getting pinched, it gets inflamed, it gets swollen, it gets pinched, it gets swollen, it gets painful. And all 24 muscles aren't working well because they're not functioning normally. Your body's trying to stop the pain. It doesn't know what to do itself. So it stops those muscles, but then that tightly coordinated dance doesn't work and the shoulder just kind of spirals down. And that's why most people say, hey, I've had this pain for 2 or 3 months and I haven't gone to the gym, I haven't done anything, it still hurts. Well, the reason is you need to exercise the shoulder back to health. You have to get those shoulder muscles all working well together. We mentioned that there are 24 muscles, but there are also 3 joints and then articulation. So that adds to the complexity as well. A couple of other things in the shoulder that cause problems at times are one, something called the capsule. The capsule is a shrink wrap that keeps the ball centered on the socket at the end ranges of motion, right? So like if you have see a balloon artist and he twists the balloon, it kind of tightens the balloon. And that's what happens to the capsule. As you rotate and move your shoulder, the capsule will tighten up a little bit and assist the rotator cuff in holding the ball centered in the socket. Additionally, there's something called a bursa, and a lot of times you'll see in pictures later on this talk as well. I'll show one bursa, but there are numerous bursas all over the shoulder. Now, bursas protect soft tissue, muscle, skin, or tendon that glides along bones. Okay, so you can actually see a bursa on the tip of your elbow when it swells up, or on your knee. And those bursas you can see very well. The ones on the shoulder you can't see, but you can feel them. And I'm sure many of you out there have felt it before. All right. That is what happens when the bursa is swollen like that. You can see it gets pinched as you lift your arm up in the air. Or what most people notice is, I can't reach behind my back as well as I used to be able to. And that's because the first motion we lose when we have an angry shoulder typically is the ability to put our hand behind our back. And it's also the last motion to come back once we've gotten better. There's an echo, 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 echo. Do I have an echo still, or should I keep going?
I hear you just fine.
You're good. There's no echo.
Okay. Apologies for those who have an echo. So when you come to our office, we're going to evaluate you. We're going to look at you. We're going to ask to look at your shoulder. We're going to ask you to do some things. The problem with coming to see an orthopedic surgeon, unfortunately, often means we're going to hurt you. And we are sorry, we don't enjoy hurting you. But in order to figure out what's wrong, we need to figure out what causes pain and what causes reproducible pain. So we're going to put your arm through a number of motions, and we're going to see, does this hurt when I pinch here? Does it hurt when I press here? I'm going to do things like a Neers test or a Hawkins test. I'm going to ask you to push out against my hands, push in against my hands. Don't hurt me. Lift your hands up in the air. Can you hold it there when I push? Can you press on your tummy? Can you lift your hand off your back? These are all motions we're going to see. Can I put your hand up in your hair like in the air like this? And you're not going to be afraid of your shoulder dislocating. So these are all tests we're going to do. We're going to check ranges of motion. I'm going to ask you to lift your hands up in the air. I'm going to ask you to rotate your arms out to your side. I'm going to ask you to put your hands behind your back. Those are the three basic motions of the shoulder. We call them elevation, external rotation, and internal rotation. And this is something I'm trying to teach, and I haven't. Those of you out there who might be savvy, don't think of it. I've got to get this copyrighted or trademarked. This is what I call the safe box. Our shoulders, I want you to think about our ancestors, okay? Because most things that lead to problems that lead you to come to my office are because you're doing things outside the safe box. You're using your shoulder in a manner in which it was not supposed to be used. This is the safe box. Our shoulders are designed essentially to bring our hands, not in such a rigid box, but to bring our hands out in front of us, okay? Why? Why does our shoulder need to do that? Well, our shoulders are designed to hug and to love. They are designed to protect yourself. They were designed to punch to protect yourself. And they are designed to climb or reach for things above our heads. Okay. That's what our shoulders basically designed to do. If you want to imagine, if you believe in evolution and we kind of walked like apes or chimpanzees, our shoulders and hands are always in front of us and we reach for stuff when climb. But just like chimpanzees we shouldn't be putting things in overhead bins either. Your shoulder is not designed to place things over your head or up on high shelves. Okay. Pushing things is a very different mechanical force than pulling. Pushing is a much stronger force and a much more stressful force on your shoulder than pulling something. So those of you who do this, stop doing this. Stop putting things up on high shelves. Be careful when reaching into the refrigerator. Keep things down at shoulder height for more than one reason, by the way. We don't want you getting up on step ladders or chairs and ending up in our office falling off one of those ladders. Our ancestors did not reach out for parking tickets or into the back seat of their car. It would cause you to wince. It hurts. You're using the shoulder outside the box. These muscles are not meant to bend forward and then backwards and sideways and down. You're pulling these muscles out of phase. Our ancestors did not loop their belt or wear a bra. So reaching behind your back is very uncomfortable when your shoulder is injured or inflamed. So I want you to remember that. Respect the box. Furthermore, I didn't put the slide. Keep things close to you. Don't reach too far for things. The further you reach, that's like a long lever arm or crowbar. T-Rex arms, alligator arms, keep things close to you. Keep things in front of you. Don't reach too far, because the physics of it is, although my water bottle may only weigh 16 ounces when it's close to me, the further I reach, it develops a force of 2 or 3 pounds on my shoulder joint. And the shoulder joint is about the size of a quarter. That's a lot of force in that little joint. Next up is Dr. Cui. He's going to fill us in on some of the basics of some of the imaging you might expect for us to order. We want to see your shoulder from the inside.
All right. Thank you, Dr. Miller. So the most basic image that we would order, and it's done the same day, probably just across the hallway, is an X-ray. This gives us a good evaluation of the bones and the joint space of the shoulder and the empty space above the shoulder joint, called the subacromial space. So as you see on the X-ray, there's numerous bones that come together to make this shoulder joint. We could see if there is loss of joint space. That is where the cartilage lives. That can tell us if there's any signs or concerns for arthritis. We could see if there's any fractures, if there's any displacement or movements of pieces of bone. We can see even if there was a far distant injury, if the bone healed slightly crooked, we could see deformities. We could see some people, their bones don't grow together, so they might have an extra bone around the shoulder. And also, if a surgeon was in there and they left plates and screws, by all means, those will show up very, very prominently on these X-rays. Can you go to the next slide? So here's an example of a normal shoulder on the left. As you can see, the ball and socket, golf ball and tee, I say spaghetti on a meatball on a spaghetti plate. On the left, there is a nice empty space between the round humeral head on the left and the glenoid, which is the golf tee in Dr. Miller's analogy. That is where the cartilage lives. The cartilage is the smooth gliding surface that allows our joints to move without creaking or groaning. Unfortunately, as we age, just like the tire rubber wears down with miles, so do the cartilage with the years on our life. So on the right is someone who does not have a good cartilage joint space. You can see that the bone is touching, where you'll frequently hear the term bone-on-bone arthritis. I would suspect the patient with the X-ray on the right would have if not a creakier joint, a joint that might not move nearly as far. They might not be able to, reach into their back pocket. They might not be able to go overhead, or at least not painlessly as they used to be able to. Arthritis comes from a lot of things. Most commonly is just making it past a certain age. We were not designed to live past, depends on who you ask. But we are definitely outliving what our bodies are capable of doing. So that's something that'll come up. Other things from an arthritis standpoint, it could come from a prior injury. So if a fracture involves the joint space, the cartilage could be injured. If a shoulder dislocates, the cartilage could be sheared and injured, in which case it puts more kind of miles on the tire. We can go to the next slide. So speaking of injury, on the left, this is a broken shoulder. It is a pretty badly broken shoulder. I hope you can see that compared to the X-ray on the right. The ball portion is in at least 3 pieces that I can see, potentially even more. So this is something that you'd remember how this happened, and most likely you'd be taken to a hospital and we try to do surgery to put those pieces back together so the ball heals in the correct shape. If we left it there, it would heal, but then it might not heal in a shape or position that's conducive to the shoulder's function. Now, the X-ray on the right, you can see that the ball and the golf tee are not pointed towards each other. There's a shoulder dislocation. It could happen in sports all the time. Someone takes a big hit. It could happen with a fall. It could happen with other trauma or someone yanking the arm in a way that it's not supposed to go. So what we don't see with an X-ray and what we'd have to send out for is an MRI. These are the things that would evaluate those rotator cuff tendons. There are other soft tissues such as the biceps tendon. There's a labrum, which is kind of like a bumper around the golf tee. to keep the joint aligned. So this picture is, you see the black line above the ball, that is the rotator cuff tendon. There is a nice white space in the middle, which is either showing a lot of inflammation or most likely a tear completely, so that continuity is disrupted. If the tendon is not attached to the bone, the muscle pulls, but then nothing reaches to the bone, so the bone can't move to move your joint. So that's why frequently with the rotator cuff tear, people have their arms kind of stuck down by their side, can't really go reach overhead. This is incredibly useful. Sorry, go back. This is incredibly useful and almost required, in my opinion, when planning a surgery, because we do not like to do exploratory surgery. I don't like to be surprised when I get in somewhere. I'd like to have all my ducks in a row and all my contingency plans ready and available. So.
Yeah, we use it as an adjunct. Like I always tell patients, like the first time I see you, Dr. Quinn, I can examine you, we can look at the x-rays, we can listen to your story. Most of the time, within a few seconds, actually, with all due respect, we kind of know what's going on. And what we tell people is just to trust our MRIs. An MRI is really used as we're further along in treatment or we are considering a surgery. That's the way I look at it.
All right, so moving on to common diagnoses. First up, a frozen shoulder. It's something that we call adhesive capsulitis. It just means the capsule that holds all the ligaments around the ball and the golf tee, they get inflamed, they get upset, it hurts to stretch them. Therefore, the shoulder gets kind of tight. It does have some genetic component to it, and it does seem to have a predisposition to affect middle-aged women and patients with other conditions such as diabetes or thyroid issues. So the tightening of this capsule restricts the range of motion. Usually there are 3 stages: a freezing stage, a frozen stage, a thawing stage. Kudos, whoever named that made it really nice and easy. So a freezing stage, you'll notice the range of motion is decreasing, it's decreasing. It hurts to move because it pushes to a point where just the shoulder is unable to stretch that much. Then it kind of sits there and it's frozen. That lasts for some amount of time, and then it thaws. You notice that the range of motion starts to come back. It's usually self-limiting, so almost regardless of what we do, it gets better on its own. The things that we can do as orthopedic surgeons is to try to help you get this motion back sooner. The mainstay is supportive treatment. So sorry. Supportive treatment such as physical therapy. We could, look for like distension of the capsule or fluid in the joint space with ultrasound, but usually it's physical therapy plus or minus a steroid injection to try and calm down that inflammation. Next slide.
Actually, the last point was that one of our partners, Dr. Gruner, he's a
Yes.
non-surgical sports medicine specialist. He does a lot of ultrasound guided procedures in the office. He has had wildly successful outcomes for capsular distension under ultrasound. We're in the office, he numbs up the skin and the joint a little bit, and then he can see the needle go into the joint. And historically, we used to take patients to the operating room and just yank their arm and tear the capsule or operate on it and cut through the tissue. He's able to do this in the office, and it has been remarkable to me. I didn't actually buy it and buy into it until I saw the results in some of our patients, and it's had a great success for my patients to shorten the duration of the disease, which in can be months for the painful phase, but to return to normal full range of motion can be up to 2 or 3 years. So the capsular distension with Dr. Gruner is an outstanding option for some of our patients.
I already gave my little arthritis spiel, but here you can see on this x-ray, it's much more advanced than the one I showed you before. So this one, the ball's kind of flattening, the joints are kind of slow motion train wrecking into each other. The humeral head is actually shifting superiorly, so up on the image and bumping into the acromion, the bone that's above it. The rotator cuff lives in that space. So in this case, if I were a betting man, I'd bet that the rotator cuff tendon is also completely destroyed. So,
Speaking of,
speaking of that, a rotator cuff tear. It's also possible in young athletes. Usually, it's a throwing type injury. In older patients, it's could be degenerative. It's slowly as the shoulder ages. Usually, these tears start showing up sometime in our mid 50s, early 60s. They could be partial or full. My my number, I guess I just made it easier in my head. I say 60% of people at around the age of 60 just have a rotator cuff tear. It can be partial, it could be full thickness. Both of them can be painful. Next slide.
Yep. Yeah, and I say to people, like, our tendons are like ropes. Unfortunately, over the course of our lives, the ropes are braid and thin, and we all live in this continuum.
Yeah. So you can see it ranges from a healthy tendon to the first one on the left, tendinosis or tendonitis, just inflammation, tendons upset. It's still intact. It still can do its job, but that's usually like a painful range of motion. A little more advanced is a partial thickness tear. This could be either on the side of the bone, we call that joint side, or bursal side, if it's between the humeral head and the acromion. So the red arrow would be a bursal-sided partial thickness tear. And the tendon starts to peel off, and that can, well, be painful. Putting force through a partially torn or upset tendon would be painful. And then finally, if the whole thing pops off either traumatically or through just time and use and wear and tear, then the rotator cuff tendon no longer can pull or move the bone. So right next to the rotator cuff is a bursa. It's a bursa. A bursa is a kind of fluid-filled sac. You can think of it like shock absorbers that try to pad areas that we see a lot of motion. We famously have a bursa at the tip of our elbow. If you know anyone who had elbow bursitis, it's like a little orange or clementine hanging off the tip of their elbow. We also have some in the shoulder, specifically between the rotator cuff tendon and the bony roof, the acromion. So a bursitis is an inflammation of the bursa, which would cause pain with motions that cause the humeral head to push up into it. So we could call this bursitis. It's on the scale of impingement, subacromial impingement. Usually that's one of the motions we move you around to try and, unfortunately, elicit that pain so we know what's going on in the office. So, if someone had a trauma, there could be small fractures, but very critical pieces that could lead to chronic instability of the shoulder. So what you see here is an MRI and then a 3D CT recon of something called a glenoid fracture. Dr. Miller said that the glenoid, that golf tee, is about the size of a quarter. So it's not a lot of real estate. If we miss even like 20, 30% of that, that shoulder could dislocate. It could easily slide off, leading to a painful motion, sometimes even a locking if the shoulder dislocates and gets stuck. Other issue, so moving on to dislocation. Other things, if it's completely unstable, things could dislocate. It can go in and out. There is an exam mover where we try and purposely twist and see if the soft tissue and the structures around the shoulder can resist that motion. Some patients, we call it the apprehension test. They get that feeling of, ooh, something's going to pop out. And then if we could push that shoulder back, give some external stability, and it feels better, then we know the internal structures are not strong enough to keep the shoulder in a nice stable position. Most commonly, this is due to a trauma. So we start off, even though we're surgeons, we try to do everything that's not surgery first. So non-operative treatments. Next slide. First thing, like any soft tissue injury, rest, ice, compression, elevation. If you have a day where you do a lot of activity and then your shoulder hurts that evening or the next morning, take it easy, kind of like having a twisted ankle, put some ice. You could use a sling if you'd like, but I just caution you, if you hang out in a sling for weeks, the shoulder is going to get very stiff. You could potentially give yourself a frozen shoulder that way. The elbow could also get stiff, so use it judiciously and if you need it. Even for small rotator cuffs, tendinosis, things like that are a good treatment you could start at home. Tylenol, ibuprofen, just the over-the-counter pain medication could help make it feel a little bit more bearable. The main thing that I want to caution is some people, they try to self-treat a little bit too much. The thing I would be worried about is if something happened and range of motion is lost. Even if it's painless, if you can't move it, I worry that a rotator cuff tendon could have completely ruptured, so nothing's pulling. For specific motions of the shoulder, I'd be worried about a dislocation. If the ball and socket or the golf tee and golf ball are no longer congruent, that would be something that I want to see more urgently. So we don't directly do physical therapy, but we do work with numerous very well-trained physical therapists and occupational therapists. This is like therapeutic exercise for the shoulder. So even with rotator cuff tears, even with complete rotator cuff tears, physical therapy can show some pretty surprising results in that strengthening the remaining muscles that are attached can help better stabilize the joints. You can find different ways to put that arm above the head, even though that's outside of the safety box. I'm sorry, Dr. Miller. It can also help with flexibility for things like a frozen shoulder or stiffness after a surgery or an injury. And they can teach proper mechanics. That's where keeping things close to the body while lifting. Try not to, lift far behind and away from you, and help oversee and encourage and sometimes push you, kind of like a personal trainer, on how to do things and to continue with the exercise to strengthen your shoulder stabilizers. So we discussed frozen shoulders. They can help stretch. Oh, sorry, I was going to run through it real fast. Frozen shoulders, degenerative rotator cuff tears, even in arthritis, it might be a little creaky. It might feel like dragging a cinder block across concrete. But as long as, from an arthritis standpoint, as long as the flexibility is there, if it doesn't hurt, hey, you're winning at that point. So physical therapy can definitely help there. Simple dislocations, if it pops back in place, usually they'll keep you in that safety square, and then slowly as the tissues start to scar down and regain their stability, they can move you to wider and wider ranges of motion. And of course, post-operative recovery, us, the surgeons, will probably tell you, don't move it for a little bit. We want the scar to set in, heal, the shoulder's going to get stiff. They can help regain that range of motion. Next slide. This probably should say operative, but this one's more of a semi-invasive, but can be done in the clinical setting. This is a corticosteroid injection. So the idea is, you've heard of NSAIDs, non-steroid anti-inflammatory drugs. Well, this is a steroid anti-inflammatory. Also known as a cortisone shot. We use cousins of cortisone, but they're all in the same steroid family. The idea is we could take a needle. It's usually doesn't have to be that long. And to get it into either the subacromial space, if there's a bursitis, we could get it into the actual glenohumeral, the joint space itself. If there's things like arthritis, we can go in either side if there's a rotator cuff tear, because again, the rotator cuff, one half touches the subacromial space, the other half touches the joint space. It might not directly address the underlying issue, but it can certainly help. A bursitis, which is inflammation, if it's not caused by impingement, this directly addresses the inflammation. Could be very helpful there. It could also help the pain from the inflammation if you are doing things like physical therapy. So it could help you better engage with the therapist and to strengthen the muscles, which would address the underlying potential instability, tears, lack of range of motion with arthritis. All right, let's switch it
Yeah, I
back.
was gonna say, we won't get any injections ever again if people think the needle looks like that. It doesn't look like that. It's much smaller than that.
Yep. Back to you.
All right. Well, this is the money stuff. This is what we train so hard to do. This is what our expertise is in. So there are different ways to treat shoulder problems when all else has failed. And unfortunately, there are some times where the shoulder just isn't going to heal itself on its own. We have to assist it. There are open procedures, which we'll touch upon in a second, like a shoulder replacement. But nowadays, most of the things around the shoulder we can actually do through teeny incisions, through shoulder arthroscopy, where we stick a camera in the shoulder, and through other little stab wounds around the shoulder, we can fix almost anything around the shoulder except to replace it. So this is a picture of like a shoulder arthroscopy. And this picture in the left hand is the camera, and we will look on a TV screen across from you. And in the right hand, it's something called a shaver, and it's inside a cannula. And that's how we reach inside. So we have what's called a viewing portal on the left side and a working portal on the right, so we can see what we're doing inside of the joint. Shoulder arthroscopy, as stated, can treat almost anything except for replacement, and this is most commonly used to treat rotator cuff tears. Like I did today, we do shoulder surgery, shoulder stabilizations for people whose shoulders are dislocating due to damage to the socket, or as Dr. Cui mentioned, the labrum, which is a soft tissue washer around the socket, which deepens the socket. If that gets peeled off, that is like having your, let's say, the instead of the golf tee, or you can say the golf tee, if you break off the rim of the golf tee, the golf ball is going to slide out of it very easily, roll off of it. When the labrum tears, the shoulder can slide out of the socket more easily. We can treat biceps issues, tendonitis or tears. And in some cases, if the bursa that's inflamed for a long time, it becomes very, very thickened and fibrous, and it just won't go away. We have to go in and remove it. And that's what shoulder arthroscopy is. These are some pictures from a shoulder arthroscopy. This is what a rotator cuff tear may look like. This is a nice, small, manageable tear. As you can see in the before picture, top left, the white is the rotator cuff tendon where it says hole. We can actually see into the joint. We're looking from the outside into the shoulder joint. We shouldn't be able to see a hole looking into the joint. And that's because that rotator cuff tendon edge has pulled away and exposed the bone. On the right side in the top, you can see my little metal instrument is stuck in that hole, demonstrating how there's a communication between the joint and the space outside the joint where the bursa normally is. And in that picture, furthermore, if you look above, there's a stalactite or stalagmite. I can never remember what it is. That's called a spur. That's a spur that may have rubbed onto this tendon over time. And there's not much space, therefore, between that spur that's hanging down and that rotator cuff tendon above it. Can you see my cursor or no? So this is the spur, and this is the tendon. There's not much room. This is where we want more room, and we may shave that spur away. So how do we fix this? Well, we need to tie this soft tissue back down to the bone. The way we do that is with this thing called an anchor. And that is this thing right here. It's a little plastic screw which has stitches in it. So we insert that into the bone, and then I take my little instrument and pass the stitches, and Dr. Cui will pass our stitches through the tendon, and then we will tie that back down and attach it to the anchor. And now where once there was a hole, ta-da, there's no more hole. This tendon is attached to the bone again. But this is the inherent problem about rotator cuff repair. I'm taking a soft tissue and attaching it back to the bone. And quite frankly, this is a problem that has to do with biology. Normal tendon doesn't tear like this. You don't get a hole in a normal rotator cuff. The tendon will tear as we get less young, i.e. older, and the tendon loses its elasticity, its strength. And therefore, our sutures initially and our anchors initially are stronger than the tendon that we're repairing. And that's why the recovery is so long and it takes a while, right? There's 4 phases to the recovery. The rotator cuff repair takes about 6 months of supervised rehabilitation, 4 phases, 6 weeks each. The first 6 weeks is the protection phase. You may do a little motion with the physical therapist, or you may not, depending upon the quality of the tissue and the repair that was done at the time of your surgery. You may be asked just to stay in that sling for 4 to 6 weeks, only coming out of it to move your elbow, forearm, wrist, and hand, maybe to do what's called a pendulum exercise, but that's about it. In other cases, we may ask you to remove it, but you don't move it on your own. The physical therapist will move it for you. That's phase 1, that's protection. Phase 2 is called range of motion and rhythm. When you come out of that sling at 4 to 6 weeks, your shoulder's going to be very stiff. And all those 24 muscles all together, even though I may have only repaired 1 or 2 muscles, all of the muscles shut down and atrophy over those 4 to 6 weeks. So when you come out, you do funny things. You don't lift your shoulder normally, you hit your shoulder like this. And so we need to restore normal motion and rhythm of the shoulder. That's phase 2, rhythm and motion. We are not going to allow you to lift anything more than a cup of water because that interface is still not solid enough where I repaired that tendon to your bone. That gets us to 3 months. And phase 3 is the beginning of the fun part. That's the early strengthening part. Now we're going to start to add some light weights, some resistance bands. And then that gets us to 4.5 to 6 months. And we'll start to talk about late strengthening, returning to play programs, getting you back on the pickleball court or wherever you choose to get back to. The sad reality is, and I can't change this, is that rotator cuff surgery stinks. It hurts. It's painful, but we'll give you lots of medication as necessary. You'll use some ice, and we'll tell you how not to aggravate it. And again, these 6 months of recovery are not negotiable. There's no negotiating in the office. Can I go back to work at 3 months as a bouncer? No, you cannot. This is a 6-month recovery. We are at the mercy of the biology of our body. We can't rush it up. And by the way, even though we're saying 6 months is the supervised portion, you will continue to see increases in motion and strength and function for up to 2 years after your shoulder surgery. Another common problem we see a lot of is shoulder arthritis. And we touched upon that in some x-rays. And this is an ugly arthritis shoulder picture here with a big giant bone spur. We call this a goat's beard osteophyte or a goatee. And there's no joint space left. Historically, we used to do what's called a hemi, which is where we'd replace only the ball, only one side of the joint. And that's been now kind of relegated to the trash bin of history, except for certain cases for catastrophic problems where the socket is irreparable or we cannot reconstruct the socket. Most of the time, our patients, 99% of the time now, are getting either a total anatomic shoulder, conventional shoulder replacement. That means conventional means I'm replacing the ball with the ball and I'm resurfacing the socket, okay? This is a total shoulder. This is a resurfacing implant. This is the minimally invasive type of replacement where we're just replacing the surface of the ball and the surface of the socket. This is done in younger patients that have good quality bone, that have a normal, healthy rotator cuff, because anatomic or conventional shoulder replacements require you to be younger and have a good, strong, healthy, normal rotator cuff because there's no constraint here. We need, just like your normal shoulder, those muscles, tendons, and capsule to keep that ball centered in the socket. So this is generally going to be for patients under 65 who have good health, who are in good health, have good tendon quality, no significant pre-existing rotator cuff injury. Nowadays in the United States, in fact, when I started, we did a lot of hemis, we did a lot of anatomics, and we just started to get reverse replacements around 2002. I believe the FDA authorized it 2004. And at first, the reverse replacement, which is this next picture here, where we've reversed the ball and the socket, this was indicated, very narrow indication initially for a very specific subgroup of patients. We've had such great success now that the reverse replacement has now exceeded the number of anatomic shoulder replacements we do in the United States annually, almost 2 to 1 or 3 to 1. And when we talk about shoulder replacements, by the way, we don't do nearly as many shoulder replacements in the United States as we do hip and knee replacements, right? I think nowadays, I'll say we're about, I don't know, 100, 150,000 total shoulders annually, I believe it's about. And in the United States, we do probably 500 to, I think about 500,000 to 600,000 hip and knee replacements annually. So it's not as common. So that's why many people say, oh my gosh, I heard total shoulders are terrible. It's so hard. Well, that's not true. Dr. Cui and I are high volume shoulder replacement surgeons. We do these weekly. We use the latest technology, and it's an excellent procedure for the right person. In fact, this reverse procedure allows me to get my older patients who are losing their independence because their shoulder hurts so much, it doesn't function, they can't lift their arm anymore. I typically will have my patient in this thing only for a couple of weeks, and you can come out of this. This recovery from the reverse replacement is significantly shorter than a rotator cuff repair, and it's even shorter than an anatomic repair. And these are just a picture of some of the other, the replacements and plates and screws we have to manage all types of shoulder problems. I do what's called computer navigation. I use real-time navigation when I'm doing a shoulder replacement. What that requires is we get a CT scan of your shoulder beforehand. I use the 2D pictures of your shoulder on this screen here, and then we transform that into a 3D model of your shoulder on my computer. And then we can plan your surgery on the computer. So when you come to your preoperative visit with me, we'll be able to look at what I think your shoulder is going to look like, what I plan to do to your shoulder. And then during the surgery, in fact, I am using the computer. And at times in this picture here on the left, I'm not even looking in your shoulder. I'm looking up at the computer screen. And on that drill in my right hand, for those of you who can manage the stomach seeing the bloody gloves, that is an instrument where I am actually reaming or machining or drilling the socket. And I'm not even looking inside the shoulder that time, I'm looking on the computer, and the computer is showing me in yellow. That's the drill bit as I'm drilling into the bone. I can see the bone, and that's actually the patient's shoulders and patient's anatomy right there I'm looking at. And that helps me in real time aim that drill. As I move my hand, the picture of a drill on this computer screen is going to move with my hand. So I know that I'm drilling straight down the pike into the best bone. I'm not going out the back or out the front. And that's the beauty of having real-time navigation. Another way to do this is that in this picture here, we can have special jigs made. These jigs we're looking at here actually for people who have severe, severe deformity, where in the old days, I said, not even the old days, even sometimes now, if we are unable to get a shoulder replacement in, and we can't even have enough bone stock to do one of these custom 3D printed implants, then we'll go back and do a hemiarthroplasty. But we have an incredible amount of technology and options now to help people, even with severe shoulder injuries. Shoulder replacement typically takes about 6 months for the anatomic replacements. Generally speaking, most surgeons in the United States will tell you if you're over 65, you're getting reverse. And if you're under 65 and you have a normal rotator cuff, you'll probably get an anatomic replacement. And now for the fun stuff. I haven't seen the chat box. I don't know how to get out of my screen. I'll leave this up and maybe someone else can start to throw up the questions. Or should I get rid of the screen here, Marin? What should I do?
Let's unshare, and then if you wanna, you and Dr. Quay can go through the chat. I would say start at the top and
Okay.
go work your
All
way
right.
to as many as we can until 7:30. Thank you.
Okay. All right, we'll go back and forth. How's that, John? I'll do the first one. Can a downsloping acromion resulting in impingement at the interaspect of the subarticular space cause pain issues? You know what? That's a great, great question. That acromion process, like we showed, hangs over the ball. And in some people, it can be a really sharp hook. And it can indeed rub on your shoulder, or either the tendon or the bone or that bursa we were talking about. Historically, in the old days when I trained, not Dr. Quay, in the old days when I trained, we used to think that spur, that overhanging acromion was a big problem, and we used to whack those out willy-nilly. It's actually turns out, as we've looked back over the years and done the research, that overhanging acromion may not necessarily be pathologic, meaning that it doesn't have to cause problems. It may just be a normal variant. Then that being said, if it's a normal variant and it's overhanging and narrowing the space through which travels the rotator cuff, the bone, and the bursa, well, then it takes a lot less swelling before it impinges. So yes, a laterally sloping acromion can indeed cause impingement. Sorry about the echo. So you'd have to answer that question.
I want to give you the next one. Do golf swings put our shoulders outside of the safe box?
Generally, no. My patients are usually very happy to hear they do not have to stop playing golf because no, you're keeping your shoulder in. In fact, almost every sport, except for powerlifting, your hands are in the box. Racket sports, throwing sports are if unless you have what's called a lazy arm, the arm's supposed to be in front of you. When you're doing a serve, you're reaching up at your. I hope you have the core rotation and flexibility to get up and over the ball. So no, typically golf is safe in the safe box.
Speak for yourself, Michael. So he's atrocious. So, next one. During evaluation, will there be X-rays for the shoulder or the spine as well? So, from a shoulder standpoint, we're here looking at shoulders. Of course, there'll be a shoulder X-ray, but you raise an excellent point. Anything coming from the spine, a pinched nerve, exiting spine arthritis, even trapezial or muscle imbalances coming from the neck, they can refer pain down into the shoulder. In some, usually they're younger patients, we call it multi-directional instability. It's kind of like either a weakening or an imbalance of the muscles that stabilize the shoulder. So it can come from all around the shoulder. There's many, many muscles that control it. But in the end, proximal to that is the spine. There's been numerous times where I take an X-ray of the shoulder, it looks pristine. Take an X-ray of the neck, and that's where all the arthritis has been found. So there's frequent talk between spine surgeons, shoulder surgeons, upper extremity surgeons. We have patients see each other to see how much the symptoms could be coming from one place or the other. Sometimes there could be some coming from one or the other. Sometimes it could be coming from both. So purely addressing a rotator cuff tear might not make the pain completely go away if there's also pathology coming from the spine.
Should you start therapy once inflammation is down, or can you start even with inflammation? Absolutely. Remember, we want to wake these muscles up. There's two problems. On the one hand, you have this inflammation. Remember, I said the inflammation can cause pain inhibition of those muscles. So it's our responsibility to try and get that inflammation down, either with medications, topical ointments, ice or heat or something. We need to lessen that because that inflammation can be a roadblock, and we need to open that roadblock up so all these muscles can flow and the motion can flow through there. when you start with therapy, you want to they'll want to start you out of the painful ranges of motion. But even then, we can do what's called isometric exercises, where we're not using weights or bands. We're just pushing against the movable objects. That way, we can wake up those muscles. Isometric exercises, they're called, can actually maintain and build muscle mass just as well as concentric flexion, like weights and bands. So yes, we typically will start during inflammation, but try to keep you out of the painful ranges of motion.
Next one, talking about x-rays again. Arthritic shoulders do have bones that appear thicker, or the technical term is sclerotic. That's usually the bones kind of squishing together. Bones are kind of like a dry kitchen sponge. They can compress a little bit, usually as the arthritis and the bones see more forces because of the nice gliding surface and the joint mechanics are disrupted. You'll develop things such as bone sclerosis and that goat beard osteophyte. That's a common enough one that it got its own name. But yeah, they are signs of arthritis. They can cause issues if the physical presence of these osteophytes or bone spurs impinge. They can pinch things, they could rub on things, they could cause pain just by being there.
Yes, you'll get a copy of the presentation. We got that one. Good. Thank you, Myrna. My diagnosis: high-grade partial thickness burial, low-grade articular surface T-cart. I'm going to use my, I'm going to guess that's a low-grade partial thickness bursal surface tear, and a low-grade articular surface tear. And so this is someone that's had an MRI, and the radiologist has gone ahead and looked at it. And an MRI is a digital interpretation of reality. And the radiologist is really just an art critic. So when they look at it, they're just kind of reading and telling what everything they see. And if you're over 45 or 50, your MRI is going to say hypertrophic osteoarthropathy of the acromioclavicular joint, laterally sloped and thickened acromial ligament causing subacromial bursitis and subcoracoid bursitis and subdeltoid bursitis. Partial rotator cuff tendinosis with a partial thickness bursal surface tear and a low-grade articular surface partial tear. And that may be the case, that part of the tendon has been worn away. But also you got to remember, on that MRI, what lights up and is white may actually just be swelling and fluid and water or tissue, water concentration in that part of the tendon may be different. So it looks like there's a partial tear. And unfortunately, basically, as we said, our tendons are like ropes. So pretty much anyone over 50 is going to have, to some degree, a partial tear. And it depends. Most of these, overwhelmingly, we don't know we have more. If we do have them, they're symptomatic, respond well to non-operative treatment. But if they don't, that is something you indeed will want to address with your surgeon. And that might need either a full repair, a cleanup, or a biologic augmentation. We're able to do that nowadays with some tissue. 7-year-old athlete, John.
Yep, 70-year-old athlete had a successful shoulder replacement one side. The other side's now painful with buckling seatbelts. Pain at the long head of the biceps tendon, which is an area that we poke for. At examination scheduled for an injection. That would be a steroid injection, cortisone, quote unquote, cortisone injection. That is one of the common things that we try to decrease the amount of inflammation there. If it's purely from inflammation itself, then great. It might be very, very successful. If there is some underlying other cause, such as if the biceps tendon, where that's attaching near the shoulder, if that's starting to peel off, then it might help with things such as physical therapy, like in rotator cuff tears, but it might not directly address the underlying pain cause. But yeah, it's very common to use steroid injections in all these.
Absolutely. I have a partial rotator cuff tear. Does golfing deteriorate my rotator cuff? No. Life deteriorates your rotator cuff. Time deteriorates your rotator cuff. Golfing, by all means, get out there and golf all you want. You're not doing any damage to your rotator cuff. You may be doing damage to the golf course. I don't know how you play, but no, you can go ahead and, in theory, if you have good flexibility rotation, then no, go ahead and golf. I have no problem, because generally speaking, that's keeping your arms within that safe box.
21-year-old son has multiple dislocations. Why does this happen? I'm sorry, I don't know. Doctor says he needs surgery. Wouldn't be surprised what type of solution. So there's a multiple things that could cause a dislocation. Usually the first time is a trauma. It depends. There could be a little fracture off the edge of that golf tee, off of that glenoid. It could be a tear of the labrum. all things that make it easier to dislocate. There could be a little divot that occurs in the actual humeral head that catches and kind of spins the humerus out of the proper location. So there's numerous reasons for this, depending on what they find. Usually this would be potentially a CT scan, maybe an MRI. I would probably do both to really evaluate all the things in the area. Is there any solution before surgery? Physical therapy to strengthen the areas, but if it is a piece that chipped off as part of the labrum that tore off, usually those are primarily surgical. But if it's one of those, like the shoulder muscles are kind of sloppy, that multi-directional instability, like I mentioned before, that one we could try physical therapy to strengthen the muscles to hold it there. But if it's a structural damage, usually we have to do a structural solution with the surgery.
Yeah, basically the current dogma or treatment for shoulder dislocations, I think this was put really, really well recently. It's that you don't necessarily have to treat the first dislocation, but you need to treat it before the second dislocation. So someone under 30 who has a dislocating shoulder, if it's dislocated more than once, they absolutely positively need to have this managed or addressed with a surgeon, because every time you dislocate your shoulder, you're doing irreversible damage to the cartilage. You're 10 times more likely to have arthritis in that shoulder than if you didn't. Furthermore, it's a terrible psychological burden to have an unstable shoulder. Question before that, is an articular surface tear at the critical zone measuring 1 centimeter? Someone's reading the MRI report, it looks like. Do I need surgery? As I said, you don't need surgery. 1 centimeter tear. In fact, there was a recent study that looked at patients with small rotator cuff tears. 1 centimeter is considered small. 10-year follow-up, physical therapy versus surgery. No difference. So no, you do not require surgery, but you do need appropriate rehabilitation, and you have to have appropriate expectations. I'll do the next one. This is causes of a joint diffusion when no trauma is present. Do you have an inflammatory problem? Do you have some sort of underlying arthritis? Do you have a recent illness, a recent viral? These are all things that can cause a joint diffusion. Joint diffusions make that joint swell like a water balloon, puts it under a lot of pressure, a lot of pain. And you want to get that down, and that's going to be done either supportively by not using your shoulder very much, taking it easy for a few days, ice, topical heat, medications, anti-inflammatory medications, or corticosteroid shot. It's difficult to drain. We drain swollen knees a lot in the office. It is much more challenging to drain a shoulder. We don't routinely drain shoulders, but you need to get that fluid out typically by lessening the inflammation or whatever the root cause of that effusion is.
See if I can rapid fire a few. Can you address bone spurs? Yes, Dr. Miller talked about arthroscopy. We could shave those down. I think the next one is why is the recovery for a tear for arthroscopically treated rotator cuff tear so long? I think Dr. Miller addressed that it has to heal. The tendon needs time to heal back to the bone. If we try and pull it too soon, it's quite literally hanging on after surgery by threads. These are some very strong threads, don't get me wrong, but they're hanging on by threads. You can easily have those tear through the actual native tendon again and cause a re-tear. So we want to go really, really slowly and let the tendon heal before we put force through it. Can you fix a torn labrum, then return to weight training? Yes, it's going to take a while. It's going to take a long while for the reason I just said above. Can PRP use with shoulders? This was something that I was thinking about putting in this presentation. PRP stands for platelet-rich plasma. It is something that technically is still under investigation by the FDA, so technically not FDA approved. The main thing that you'd realize is probably not covered by insurance. The idea with PRP, platelet-rich plasma, is spinning down a patient's platelets. They're the stuff that make up scabs, which their whole job is to organize at sites of injury. So inside platelets are factors that promote a healing response. The theory behind platelet-rich plasma is spin them down, isolate them, put it in an area with a tear or something that we want healing to occur at. As they break down, they release these factors to try and stimulate a healing response. I don't do them personally. I don't think Dr. Miller does them personally. Dr. Gruner, whose name was mentioned before, he's a big proponent in our group for platelet-rich plasma. He does try them for partial rotator cuff tears. It's not a good treatment for full thickness rotator cuff tears, as at that point that tendon is kind of migrating away from the bone. That's kind of a mechanical problem, needs a mechanical solution. Let's see if I can do one more.
75 question. Yeah, let's go rapid fire. Like you said, 75 questions to go.
Lost considerable cartilage of shoulder, biceps tendon, which is anchored and relocated, so that's a biceps tenodesis. Has pain, wakes up.
It's
Good
arthritis pain.
Yeah, it's most likely arthritis.
That's got it. At night pain is classic. Why does my shoulder hurt at night? Everyone says, why does my shoulder always hurt at night? We don't know why shoulders hurt at night. They always hurt worse at night. Don't have a good answer. But if you're bone on bone, there's no two ways. That is gonna hurt, especially if you're working out. Be careful how you work out.
Yeah, my theory is when you go to sleep, all the muscles also go to sleep. So the kinetic stabilizers of the shoulders, they loosen up, the shoulder shifts out of position. It sits there for who
Things
knows
get
how long you're
pinched.
sleeping. Things get
Yeah,
pinched.
things get
Yep.
pinched. Broke your
Disadvantage.
elbow while you were
sorry.
while you're recovering from your elbow. Oh, the disadvantages of a reverse replacement. The major difference is that you have a normal shoulder is a ball and a socket. A reverse, you have a socket around a ball. So what happens is we're great at getting your arm back over your head, basically, but we can't. It can't tell you what your rotation is going to be like because there's ultimately the socket hits the neck of the shoulder joint, and it can't go any further without dislocating. So that's one of the major disadvantages to it. There are others, but that's the major one people think of. So that's the major disadvantage. And there are some of the risk factors that are different as well. But it's a fantastic procedure for the right patient, and that's why in the United States now and throughout the world we do more reverses than anatomics. You broke your elbow in June from a tennis match. Your shoulder muscles all shut down, all 24 muscles. And what happens is that there's a big muscle called the deltoid. That this is the acromion, this is the shoulder below. The deltoid is the three-headed monster. And what happens is the rotator cuff muscles are small, four like stringy fingers, and they get overwhelmed by the bigger muscles. So when the deltoid lifts, it's pulling up. And if the rotator cuff is weak because they haven't used it much, it can't resist. So you'll probably get a little bursitis after that happens. Thank you for the commendations. What's a slap tear? Slap tear is a thing that was overdiagnosed for many decades when I was a young buck. We don't talk about slap tears much anymore because if you're over 30, you have a slap tear. And that being said, in some of our throwing athletes or overhand athletes, slap tear can be a problem. That means the superior labrum has torn off the top of the socket. That part of your labrum, in fact, is just an anchor point for the long biceps tendon. It doesn't have much to do with stability. So the labrum on the top of the socket mostly is the anchor for the biceps. And if there's irritation there from the biceps, then you may want to move the biceps. Back in the day, we used to fix these, and we found we were tightening the shoulders too much, so we stopped it. Nowadays, a lot of times, unless you're a throwing athlete, I call myself a biceps serial killer. I'm gonna cut that biceps and get rid of it. If it was my shoulder, I'd cut it and get rid of it. Most patients want me to transfer it. We do what's called a biceps transfer, tenodesis. How long does the repair of the rotator cuff last? Great question. We don't know if rotator cuff really even heals. In fact, if you look at an MRI or an ultrasound at 1 year or less than 1 year, you may actually see that some of that tissue is peeling off. But it's strong enough to last, hopefully, for many, many, many years. But I tell my patients, you didn't have a normal shoulder to begin with. The biology wasn't normal. We can't go back in time. As time progresses over time, we've reset the clock by repairing it. But ultimately down the road, like today, I had to revise a rotator cuff repair that one of my partners did 8 years ago. I mean, the guy got 8 great years out of it, and he's still throwing 90 miles an hour, but it finally failed again. So rotator cuff repair should last many, many years, especially if you do proper therapy. What are we covered PRP already. See Dr. Gruner, he's well versed in that, and he's very honest about his expectations for that. So our shoulders were never intended to throw a ball or swing a golf club. No, someone's missing the point. Remember, if you're a properly trained athlete, you should be having your arms should be within that box. You're swinging a golf club, your elbows are within that box. If you have good rotation, my arms are within this safe zone. Okay, when I'm throwing like this. So no, we can talk about that in the office. If you need, I can send you to it for a golf teacher or a baseball coach to show you how to properly throw a ball or swing a club. So no, that's actually a very good question, but it's not right. Shoulder debridement, that means you're cleaning out. Surgeon named Nerschel, the founder of the term for tennis elbow, Dr. Nerschel, did your debrided. That means cleaned out your shoulder. You probably had some arthritis, maybe a little tear of this and that, labrum, cuff, whatever. He debrided it, cleaned it out. That's what that means. A debridement is a French way of saying clean, débridement. Reverse shoulder recovery process more fully. You have the shoulder surgery. You may go home that night. You may go home the next day. Your arm's in a sling. When I do this procedure, your arm is in a sling for a few days. Then you can come out and start using your shoulder for light activities of daily living, eating, drinking, sleeping, things like that, especially keeping your hands here in front of you. There are other types of reverse prosthesis, and there's a fundamental difference in how you do a reverse. In those patients, you may have to be in a sling for 6 weeks, like a regular. So after either way, by 6 weeks, you're out of a sling. You're using your arm for light activities of daily living. You're taking care of yourself. By 3 months, 60 to 80% of your recovery is there. You should be getting your hand to your head, hand to your mouth, and hand down to your perineum to take care of yourself. So by 3 months or so, we just wait for this tissues and muscles to wake back up. Exercises for weak external rotation in the scapula, low rows, external rotation bands. Ask your physical therapist. Arthritis, partial tear, rotator cuff tear, pickleball 3 times a week. Why does it not hurt when I play, but hurts afterwards, even into the next day? Why, if you have arthritis and you're playing pickleball, then you're creating a little bit of wear debris, have little sandpaper in there. Some of that cartilage is flaking off. Remember, motion is lotion. So while you're playing, you're lubricating the joint and moving it. Afterwards, some of the stuff that you irritated is going to cause like if you had sand in your eye, it's going to tear. The joint's going to fill up with fluid under pressure. It's going to hurt a little bit. You take a couple days. When you're done playing 20 minutes of ice, that'll help, and that'll help you recover faster. Tendinosis. John, sure, you could PRP.
Sorry, I looked
Colds,
away
yeah, you
and
want a cold? There's no real science as far as I know between cold and heat. I tell patients whatever feels better. Personally, when something's sore, I use cold. When something's stiff, I use warmth. A lot of times it'll be, hey, warm up with something warm. Then I'm done. 20 minutes of ice when I'm done, or frozen peas. Can you do a reverse do a reverse shoulder to repair issues? This standard, exactly. That's one of those things we do. In the old days, I would take out your anatomic replacement and just put a ball back in and just do a hemi. Now, if we have with the technology we have today, we can rebuild your shoulder and put a reverse replacement in once an anatomic has failed. Torn rotator cuff, an 84-year-old woman, replace the rotator cuff, stem cell therapy. Don't There's no reason for stem cell therapy, unfortunately. You can try it. I shouldn't say no, but if you're an 84-year-old patient with a torn rotator cuff in the United States of America and in Europe, especially, you're getting a reverse for shoulder replacement if you're in pain and have a painful, poorly functioning shoulder. You're not getting a repair. It's not going to heal.
how frequently does the
How
surgeon? Yeah, oh, that's a
Yeah,
good
generally
question.
speaking, high volume shoulder surgeons, believe it or not, because you don't do them many in this country, people will say 20 to 30 shoulder replacements a year is considered a high volume surgeon. Dr. Quinn and I are doing more like 100 a year. So it's something you want to do. You got to do more than, like, the average surgeon in the United States has about 5 replacements a year. So just like hip and knee replacements, you want to find a high volume shoulder replacement surgeon.
Before I get
What do you
to
think about
before I-
PRP? Gruner
Sorry,
needs to
back
be
to the
here.
last question. Just want to correct the record. I'm still new. I have not established a good shoulder replacement practice here. So maybe the two of us combined might be pulling
He
up
knows
100.
someone. He knows someone that does some of these though, so he can
Yeah,
figure out where to send
where
you.
I trained, it was for a week. So,
Okay.
but right now,
Does the pain rate the upper arm and you need a replacement? So this is the thing too. The shoulder. Remember, 24 muscles, 3 joints, articulation. You tell me, hey, it hurts right here, or you say it hurts right here. What do you mean it's my shoulder? The shoulder has 24 muscles. The brachial plexus, all the nerves that go to your arm go past your shoulder. It is not true all the time that when I have pain here, the problem is right here. The pain can be generated from here, but you're feeling it's referred pain. So yes, indeed, can pain radiating up the arm tell you have bad arthritis, need a replacement? Absolutely, it can. Anything to reverse stiffness after reverse replacement, unfortunately, drastic measures. And you have to figure out, why is it stiff? Is it stiff because there is some irritation, inflammation, God forbid, infection? Is it stiff because the implants are too big? It's a very complex question, and you should discuss that with your surgeon. Barbitage, 100%. Dr. Gruner. Dr. Gruner should have been here tonight. Calcific tendonitis, barbitage, wonderful procedure. He does that in our office under ultrasound. And people have calcific tendonitis, it's one of the most painful conditions, comes on, it's stereotypical. Patient shows up, I don't know what I did 3 days ago. I'm just dying in pain and shoulder pain. Very few things aside from infection or calcific tendonitis come on that rapidly. And it shows up on an x-ray as a ball of calcium. in the rotator cuff. And Dr. Gruner, if it doesn't respond in our office to a cortisone injection by Dr. Cui or me, Dr. Gruner can go in with his needle and clean it out. Yes, as a double, remember I said reverse is twice the recovery, half the recovery of a total, generally speaking, in my hands, in my protocol. Swimming, is that safe in the box? Yes, it is. It may hurt during your reach, but remember, you're pulling and you're going to pinch maybe, but you're not doing damage. So technically, a well done swimming stroke is basically in that safe box, and it's a fantastic exercise. Thank you.
What do you wish more physical therapists knew for patients after part of their PT? Depends on what they're in PT for. If it's post-operative, like the rotator cuff or total shoulder, anatomic total shoulder, we need time to heal. So there is a part where we're kind of sitting there, feels like we're not doing anything. That is unfortunately purposeful. I've had some try to move it too early, and I get really concerned that you're going to rip through those little stitches that we put in. Is pre-surgery exercise, so prehab, is it necessary? I like it. So ideally, if it does, if you can do it, I would prefer that. Mostly, if you have limited range of motion before surgery, you're going to have extra limited range of motion after surgery. So the idea is to set the bar high, get the range of motion as best you can, even though it's painful. I'm so sorry. So then after surgery, it can stiffen a little bit more without losing that much range of motion. And also, if you can do PT beforehand, you'll be pretty good at PT afterwards. So it tells me that you are a good patient, and I expect good outcomes from that.
Breaststroke, swim strokes. There are people, freestyle or crawl is a good one, but you don't want to do side stroke, and it's going to be hard to do backstroke sometimes. So be careful of those. But breaststroke typically is quite good. Doggy paddle works well too. That keeps your hand right in the box. And also, if you're having problems, don't forget you get on a kickboard. Weighted vests, by the way, very controversial. I was looking at this recently. Not really sure weighted vests are a great idea for anyone. And anything you do that doesn't hurt, I'm all for. So if you wear the weighted vest and it doesn't seem to bother your shoulder, go for it. Just don't carry the weighted vest over your head the whole time. Then it'll hurt your shoulder. Tell whether my calcium deposit is arthritis. Your doctor should be able to show you whether the calcium deposit is actually calcific tendonitis, or if it's a loose body or piece of calcium in the shoulder. Sleep is hard because of pain. Put up with it, get better. Yes, ice, heat, Tylenol. Believe it, Tylenol is still a safe medication. Ibuprofen, if appropriate, you can take that as well. Ice or heat, maybe before you go to bed, is not a bad idea. Competitive driver, active muscle in the cars is bad for your shoulders. No, it's not bad for your shoulders. Just don't crash. Pain in the biceps. Again, you can't tell me my biceps hurt. You don't know where that pain is coming from. There's no red dot that says I'm hurting right here, inject me here. I call it subacromial pain. Sometimes if you had an MRI, you can see where the damage is, but to say the other adage we were taught as shoulder surgeons that biceps pathology does not occur in isolation. The biceps is trying to help the shoulder. If there's a problem with the biceps, there's a problem with the rotator cuff or the bursa. Blah blah blah. I have tears, swim, do whatever you can. Don't worry about it. If it doesn't hurt, do it. If it hurts for the next day, it's okay. If it hurts 2 days later, then I'm worried. I had the 2-day rule. If I do an activity and it hurts while I'm doing it a little bit the next day, but 2 days later I'm back to baseline, you're fine. You're not compounding the pain. But if you're in pain, you pass this painful threshold, then it's better. You pass, you cross, but you just don't want to go past it and compound the pain. Open surgery, no. You shouldn't need an open rotator cuff repair most of the time in today's day and age. Maybe a mini open rotator cuff repair, but most people are able to do all rotator cuff repairs through the arthroscope. Biceps move down your arm, leave it there. That's where your biceps wants to be. That's called a Popeye deformity. The long biceps tendon is the appendix of your shoulder. Okay, there are two parts of the biceps of the shoulder. The short head, which is 85% of the power and strength of the biceps. By the way, the biceps isn't the primary elbow flexor. The biceps turns your palm up in the air. The strength and power for the biceps is turning your palm up. Of that, the long biceps that move down your arm is only worth about 10 or 15%. So if it was my arm and I had a bad biceps, I would literally cut that biceps and let it fall. I don't care about it. It's the appendix, doesn't have a lot of function, causes lots of problems. When do you go for more aggressive interventions? When less aggressive interventions aren't working. You've failed non-operative treatment, physical therapy, activity modification, non-steroidal medications, orthobiologics, plate-rich plasma, stem cells. And when someone says to you, "I don't know what to do anymore," then you need to figure out what are other options. What shoulder muscle is likely implicated with a pound you see in a patient? Most commonly injured is the supraspinatus, the one that lifts your hand up. So this is usually the one people have the biggest problem with. They get weakness with overhead and sometimes external rotation. But it's the supraspinatus muscle typically is the one that causes the most problems. It's usually also the first and most common rotator cuff tendon to tear because of that probably a low overhanging spur, but also because of the blood supply to it. Does tendinosis lead to bigger problems for older adults? We all have tendinosis. It's annoying. It hurts. It's the common cause of tennis elbow, Achilles problems, patella problems, and rotator cuff problems. It doesn't necessarily cause bigger problems, and typically, if you modify your activities, do some therapy, appropriate therapy, rehabilitation, exercise, you should be fine. John, you're up. A few more of these.
See how far I can
Dumbbell
go.
shoulder press. No, you do not do this. This military overhead press my head's gonna explode. This is not a normal motion. Our ancestors never did dumbbell presses. Don't do dumbbell presses. Actually, take that back. Everyone on here should do dumbbell presses every day, and that way I can feed my family and send my children to college because you're gonna be in my office with shoulder pain. But no, in all reality, do not do shoulder presses. They are dumb. And I'm trying to retrain people. Remember, you need to use your body as it was intended to be, as it was designed. And doing an overhead press is not the way your shoulder was designed.
Local pain method to use for a paralyzed diaphragm. I think that's out of the scope of my expertise. That is the breathing muscle, which is a little far from the shoulder. I apologize, I don't know.
Yeah,
Can
it's tough.
sleep,
That's a hard one to treat. Yeah.
yeah. Can sleeping on your stomach with hands above your head cause AC joint arthritis? Potentially, but sleeping on your stomach is probably way worse for your back. So there are many more potent reasons why you shouldn't sleep
And
face
if you're
down.
over 30, you have AC joint arthritis. So it's not causing arthritis, but it may be aggravating it.
Yeah. Yes, we take both neck and shoulder x-rays sometimes. Why do people over age 65 receive reverse? Because most of people over 65 have rotator cuff tears. An anatomic shoulder replacement needs a functional rotator cuff. So that's why we usually go reverse around 65. The idea is ideally 65. Hopefully at that point, the the reverse will last the rest of your life.
Rock climb is
Thoughts on
great for knees and arms. Again, try to keep your hands here. The one that's going to get you in is going to be the far reaches if you're getting really fancy in those high difficulty climbs. But generally speaking, if you're kind of keeping things kind of close, and you should, as a good climber, really rely on your lower extremities to kind of do a lot of the pushing. You're just kind of stabilizing, so should be okay. But it's going to be a while to get back.
long-term medication needs after shoulder replacements? Hopefully none.
Hopefully,
Short
that's the
term,
point of it.
Tylenol,
Mhm.
ibuprofen, maybe some narcotic pain medication. But if the shoulder replacement correctly addresses the pain driver, then hopefully none. There's no need for any like anti-rejection or like immunosuppression if that's what you're going for. So none. I have cervical radiculopathy, had injections, but the
Spine
pain came
surgeon.
back. Spine surgeon. If the pain went away with an injection around the
Yeah,
spine, the pain's coming from the spine. Steroids
that
usually
sounds
are
terrible.
temporary. I'm so sorry. How
Yeah, it's
far would you
terrible.
remember? How far apart in time would you recommend if both shoulders need to be replaced?
3 months minimum typically. If you're doing reverse and once you can feed yourself, take care of yourself.
Yes.
I'm happy the shortest interval I've done is usually 3 to 4 months, but you've got to be pretty good health because don't forget, surgery is a major, major life stress. And not only is it that we want the shoulder to heal, your balance, your nutrition, your body needs months and months to heal because you're hypermetabolic. You need so many more calories. Good. So it takes a while. Don't be in a rush too much. But if you are, really think about good nutrition and getting yourself back into shape, because that can cause problems with the second shoulder if you're not fully recovered from a physiologic standpoint, if your nutrition isn't good. So, but typically 4 to 6 months, 3 months is pushing it. Full motion after reverse. Again, you should have good elevation, and all the time, a lot of times, even in knee replacements as well, your preoperative motion sometimes dictates your postoperative range of motion. That being said, for reverse, when your motion is limited because you don't have a functioning rotator cuff, we should be able to get your hand back over your head. Again, what we can't predict is, can you get your hand all the way behind your back? The arc of rotation from out to your side or behind your back is limited based upon the nature of what a reverse is. It's a socket around a ball. It can only rotate so far before it dislocates. So, no, you want to have full motion. You want functional motion. cracking sounds, well, if you fell and you broke your shoulder, that's one thing, but otherwise it could just be some bursitis. And as we get older, man, those bursas, everything gets kind of like rough, and it's not necessarily a bad thing. I say as long as it doesn't hurt, I don't worry about creaking. Yeah,
We're
bring it.
at 7:45.
I'm sorry.
Just no, sorry. So let's wrap it up. Thank you to Dr. Miller and Dr. Cui. I know there's a lot of questions and inquiries. I recommend once we send out everything, there will be a link to schedule appointments with Dr. Miller and Dr. Cui. So please feel free to do that. Thank you to both of you guys. I learned so much, and I'm pretty sure everybody else did. Thank you so much for your time.
Thank you all. Have a good night.
Have a good night.
Thank
Bye.
you.